Hi everyone, this is your At the Bedside Case of the Week. This is an 82-year-old female with no pertinent past medical history who ambulates in the community. She comes in after tripping over a step and falling onto her right knee, denies head strike or loss of consciousness, and complains of significant right knee pain and swelling. Vitals are normal. Before watching this week's video, ask yourself, in any significant knee trauma, what parts of the physical exam of that extremity are imperative? If the patient has negative x-rays but can't bear weight, what other imaging should you pursue to rule out fracture? Fracture of the knee can have a lot of complications. There are a lot of arteries and nerves that run around that area, and especially in younger patients, it's usually involved with a high energy mechanism. So we have to do an excellent physical exam. So let's look at the swelling. Is there a lot of swelling? We're worried about a big injury here. The compartments, are they soft or tense? Are you worried about a compartment syndrome? Our patient had pretty tense compartments. Distal pulses. Look at the dorsalis pedis or posterior tibialis. You might be concerned about a vascular injury. Sensation. Are all the areas of sensation intact? And finally, if you are concerned about vascular injury or compartment syndrome, you might need to do ABIs to evaluate this. That would be the next step. Finally, you're also going to want to look at joint laxity. However, we're not going to discuss that in this video today. Now, what's your differential diagnosis for a knee fracture in order from superior to inferior? Is it a distal femoral fracture? Well, that's dangerous because, as you can see, the femoral artery and nerve run very close to that area. Is it a patellar fracture? Or, just underneath the patella, is it a tibial plateau fracture? These are often hidden on x-ray, so you can't see them. And they're very dangerous because they're very high energy mechanisms. They have increased risk of compartment syndrome. Inferior to the tibial plateau is the tibial tuberosity. If you had tenderness there in a young person, you might think about jumper's knee or Osgood-Schlatter disease for those of you taking your boards. Something else to always consider in traumatic knee pain is a knee dislocation. These are orthopedic emergencies. Oftentimes, they reduce spontaneous prior to seeing the patient in the emergency room, so you have to have a high suspicion. They're associated with popliteal artery injuries, as well as peroneal nerve injuries. You're at the bedside, you've done your knee exam, you're concerned for significant trauma. What's your imaging plan? So start off with an x-ray. These can show signs of knee fractures, like lipohemarthrosis, which is fatty marrow floating on blood. It's basically a fat fluid level. It's pathognomonic for a knee fracture, oftentimes associated with tib plateau fractures. If the x-rays are negative and they cannot bear weight, and especially if they're elderly, if they have a significant mechanism, you've got to think about doing a CT scan because knee fractures can be a cult on x-ray. Here are our patient's x-rays, and right off the bat, you can actually see a proximal tibial fracture. However, on the lateral view, what do we see here? This is a fat fluid level. This is lipohemarthrosis. So I was actually concerned for another fracture, possibly a tibial plateau fracture. So I went ahead and I ordered a CT scan of the knee. On the CT scan, more anteriorly, you can see the tib plateau fracture, and posteriorly, you can see it a lot better here. The patient was admitted to the orthopedic service. She got surgery, she was discharged, and did well. So the takeaways for this week are always to assess for compartment syndrome and vascular injury with significant knee trauma. Lipohemarthrosis is a subtle sign on x-ray that is pathognomonic for knee fracture. And if a patient can't ambulate, has significant swelling and negative x-rays, pursue CT scan to look for occult tibial plateau fracture. We'll see you next week.